Good morning, everyone. My name is Dr. Madan Narayanan. I am a consultant anesthetist from Frimley Hospital in the United Kingdom. Today, I will be talking about the role of erector spinae plane block beyond the thorax. Erector spinae plane block is a novel analgesic technique described by Forero et al. For the treatment of thoracic neuropathic pain. The erector spinae muscle complex are paired paraspinal muscles that extend from the base of the skull to the sacrum. They lie superficial to the transverse process. The erector spinae block is a fascial plane block performed between the transverse process and the erector spinae muscle, which provides a multi-level intercostal block from a single fascial plane injection. Thoracic erector spinae block has found multiple indications. It is commonly used for analgesia following rib fractures and for chest wall and breast surgery. An erector spinae block performed at the level of T9 has been used for upper abdominal surgery and at the level of T4 for cardiac surgery. It's also been used in chronic thoracic neuropathic painful conditions. The thoracic erector spinae plane block is typically performed at the level of T4 with the patient either in the sitting or the prone position. The probe is placed 3 centimeters away from the midline to identify the tips of the transverse processes, and the 3 muscles, which are the trapezius, the rhomboids, and the erector spinae, are identified. A needle is placed either from a cranial to caudal direction or a caudal to cranial direction to contact the transverse process, and local anesthetic is injected in the fascial plane under the erector spinae, lying superficial to the transverse process. The anatomy of the thoracic paravertebral space was demonstrated by micro-CT study by Cho et al. In this study, the authors demonstrated that the superior costotransverse ligament and the innermost intercostal membrane have medial and lateral slits. So, local anesthetic placed in the posterior compartment above the costotransverse ligament tends to leak or seep inside the paravertebral space. This demonstrates the mechanism of action of the erector spinae plane block. Local anesthetic placed in the erector spinae fascial plane has 4 directions of spread. Medially, the local anesthetic can enter epidurally. Anteriorly, the local anesthetic slowly seeps into the paravertebral space through the slits, the medial and the lateral slit in the costotransverse ligament. Posteriorly, the local anesthetic can cover the dorsal ramus, and laterally, the local anesthetic spreads into the intercostal plane. As mentioned before, the erector spinae muscle complex extends from the base of the skull to the sacrum, and hence an erector spinae plane block can be performed at any level in the spine. The commonest being the thoracic, the less common are the cervical, lumbar, and the sacral erector spinae plane block. The erector spinae plane block, due to its versatile nature and its applicability in regions beyond the thorax, has been often described as the ultimate plan A block. Most of the evidence for its usage beyond the thorax have come from Turkey. First, we will look at cervical ESP block or high thoracic ESP block, which is conventionally performed at the level of T2. The original concept that the erector spinae plane block could work at the cervical levels came from the observations of Forero et al., where they injected local anesthetic at the level of T3 for a patient with chronic shoulder pain from rotator cuff injury. What they observed on contrast CT was the local anesthetic had spread up to the cervical levels and involved the roots of the brachial plexus, which is observed by dermatomal or sensory anesthesia along the fingers. So this patient developed subsequent pain relief following the involvement of the brachial plexus. Since that description of the high thoracic or cervical ESP block, multiple case reports were published for the use of the cervical ESP for shoulder disarticulation, arthroscopy, cervical spine surgery, suboccipital craniotomy, and for treatment of chronic pain due to either rotator cuff injury or clavicle metastasis, and also for excision of neck tumors and in thyroid surgery. All of these have been limited to case reports. This cadaver study performed by L. Sharkavi, looking at the spread patterns of methylene blue dye following a cervical erector spinae plane block performed at the level of C6 or C7 with 20 milliliters, demonstrated that there is deep staining of the brachial plexus roots C5, C6 and C7 with variable staining of the proximal, which is C4, or distal C8 and T1. There's 100% staining of all the dorsal rami. The phrenic nerve was deeply stained in 10% of the cadavers and very faintly stained in 20%. So this showed the potential for a cervical ESP block in shoulder surgery and cervical spine surgery where the dorsal ramus needs to be covered. But this also shows the potential that the phrenic nerve can get involved in these blocks. The cervical ESP block is performed with the patient either in the sitting or the prone position with a linear probe placed 2 to 3 centimeters lateral to the midline at the level of C6 or C7 vertebral levels. So the needle is done in plane from either caudal or cranial to make contact with the transverse process of C6 or C7, and an injection of 20 milliliters of local anesthetic is performed. When the ultrasound probe is placed parasagittally, the structures that are identified are superficially the trapezius muscle, and deep to it is the erector spinae muscle, and deeper to it lies the C6 or C7 transverse process. The needle is passed in plane to contact the transverse process, and an injection of local anesthetic is made below the erector spinae muscle. This is a summary of all the randomized controlled trials of high thoracic or cervical ESP block in shoulder surgery. In the first trial, high thoracic ESP was compared with a sham block in shoulder arthroscopy. This study demonstrated that ESP block provides effective analgesia for shoulder arthroscopy. In the second trial, which looked at high thoracic ESP versus interscalene block, showed that the interscalene block provided effective analgesia than the erector spinae plane block. In the third trial, which looked at the role of continuous high thoracic ESP block versus continuous interscalene block in shoulder replacement, showed that in patients who had the ESP block, there is no incidence of hemidiaphragmatic paresis. There was no differences in the pain scores or opioid use at 48 hours, and they recommended that a high thoracic ESP is an acceptable alternative for shoulder replacements, especially in patients where diaphragmatic paresis could be a problem. In the last trial, which looked at cervical ESP versus control for shoulder arthroscopy, cervical ESP provided effective analgesia for arthroscopic surgeries. This slide is a summary of all the randomized controlled trials of high thoracic or cervical ESP block for cervical spine surgeries. In the first trial, which looked at cervical ESP versus intermediate cervical plexus block for anterior cervical spine surgery, showed that cervical ESP provided better postoperative analgesia than cervical plexus block. Similarly, in posterior cervical spine surgery, cervical ESP versus control, cervical ESP was shown to be a safe and an effective technique with better postoperative outcomes than standard multimodal analgesia alone. Now we will look at the role and the evidence for lumbar erector spinae plane block. Lumbar ESP block was first described by Tulgar et al. In a case series for total hip arthroplasty, where a lumbar ESP block was performed at the level of L4, where the block provided a dermatomal coverage from T12 to L4, and it offered 18 hours of analgesia with a volume of 30 mL of local anesthetic. A lumbar ESP block is typically performed with the patient either in the lateral or the prone position with a curvilinear probe placed parasagittally 3 to 5 centimeters away from the midline, similar to performing a lumbar plexus block. In-plane needling is performed from cranial to caudal direction to make contact with the transverse process at the level of L4, and an injection of around 30 milliliters of local anesthetic is performed below the erector spinae muscle. Subsequent to the original description of the lumbar ESP block, there have been multiple modifications. One of the modifications is the transverse approach, where the vertebra and the transverse process are identified in the transverse plane and the needling performed either in plane or out of plane to make contact with the transverse process. The subcostal approach to the ESP block is very similar to the subcostal lumbar plexus or the subcostal transmuscular quadratus lumborum block or the shamrock block. So the contact with the transverse process is made in plane from posterior to anterior with the patient in the lateral position. The last modification to the lumbar ESP block is a two-step injection, with the first injection made on top of the transverse process similar to the original description at L4 level, and subsequently the needle is withdrawn and passed intertransverse into the connective tissue, and a further injection of local anesthetic is made. So this is a combined block of a lumbar ESP and a intertransverse block. Multiple randomized controlled trials and meta-analysis have demonstrated the use of lumbar ESP in lumbar spine surgery. There are multiple case reports of the use of lumbar ESP in hip and proximal femur surgery, in urology for pyeloplasty and prostatectomy, in general surgery, especially pediatrics, for inguinal hernia, orchidopexy, and lower abdominal surgery, and for treatment of chronic myofascial back pain, cancer pain, radiculopathy, and in trauma for transverse process fractures. Cadaveric studies of the spread of dye in the lumbar erector spinae plane block performed at the level of L4 shows conflicting results. In the study by Kodkar et al., there was spread to dorsal rami between T12 to L5. Dorsal root ganglion was 100% involved, but only in 1 or 2 levels. There was spread to the ventral ramus and posterior epidural space in 50% of the cadavers. Contrastingly, in the study by Harbel et al., a block performed at the level of L4 lumbar ESP showed that there was spread to L3 to L5 and extensive dye around the erector spinae. 100% of the dorsal rami was involved, similar to the previous cadaveric study, but there was no dye spread anteriorly into the dorsal root ganglia, ventral rami, or the paravertebral space. Radiologic studies of lumbar ESP block also produced conflicting results. On the study by Gonzalez et al., where cadavers were subjected to CT scans after a contrast injection in the L4 ESP plane, it showed that 33% there was no spread anterior to the transverse process. In 51% of the cadavers, spread was minimal and did not affect the corresponding spinal nerves. Only in 16%, the spread was extensive and reached the corresponding spinal nerves. On the right hand side, the single patient MRI scan by Selig et al., where they injected large volume of contrast and then performed an MRI scan, it showed that an L4 ESP with a large volume could have spread to the paravertebral, interforaminal, epidural, and ventral spread to the lumbar plexus. This only means that the effect of volume is not known and the presence of circulation in a live patient could cause spread of contrast as seen in MRI studies. The key differences why the lumbar ESP could be different compared to the thoracic ESP could all be explained by anatomical factors. Because of the large vertebral size, the multifidus is thicker and hence a craniocaudal spread in the fascial plane is limited as the fascial plane is larger. Moreover, the ventral rami merge to form plexus, which is the lumbar and the sacral plexus, unlike the ventral rami of the thoracic spinal nerves, which exit as intercostal nerves. The dorsal rami similarly merge in the lumbar area to form cluneal nerves. So the injection in the lumbar ESP is deeper and much more lateral. The differences in the anatomic barriers for the thoracic and the lumbar region are very different, which could influence the spread patterns. Lumbar ESP is technically difficult to perform and may need larger volumes compared to the thoracic ESP. Tulgar et al. In their case series were able to demonstrate the use of lumbar erector spinae plane block performed at the L4 level as the main anesthetic method to achieve surgical anesthesia for hip fracture surgery in high-risk elderly patients. They reported no patients had a conversion to a general anesthetic. There was no surgical supplementation of local anesthetic, and they performed the lumbar ESP block at L4 level with 40 milliliters volume of local anesthetic. Subsequently, the same authors were able to demonstrate via MRI scans of lumbar ESP showing spread to the ventral ramus and covering the lumbar plexus. They were able to show anterior and posterior epidural spread and also interforaminal spread. Lumbar ESP block was shown even in cadaver studies to 100% block the dorsal ramus of the spinal nerves. Hence, their efficacy in posterior lumbar spine surgery. Multiple meta-analyses have confirmed the efficacy and the opioid sparing effect of lumbar erector spinae plane block in spinal fusion surgery as well as lumbar laminectomies. ESP block provides less opioid consumption and postoperative nausea vomiting, lower pain scores, and longer time to first analgesic request in patients undergoing lumbar surgery compared to general anesthesia alone. In this summary slide were randomized controlled trials of lumbar ESP block were compared with active controls. In the first study, the erector spinae plane block was compared with intrathecal morphine in patients undergoing lumbar spine surgery. Intrathecal morphine provided more potent analgesia than lumbar ESP block, but the intrathecal morphine patients had greater side effects like nausea, vomiting, lower oxygen saturations, itching, and urinary retention. Similarly, in another randomized controlled trial which compared lumbar ESP block versus caudal epidural versus control in patients undergoing spine fusion surgery, what was shown was the lumbar ESP and caudal provided better analgesia than control. Lumbar ESP block provided longer duration of analgesia than caudal block and also reduced intraoperative blood loss more than caudal analgesia. This is a summary of all the randomized controlled trials of lumbar ESP block in hip surgeries. In the first trial by Agnon et al., where single shot lumbar ESP block was compared with the control group who received multimodal analgesia for total hip replacement, this study showed that lumbar ESP block did not provide a significant difference in the postoperative opioid use or pain scores. Lumbar ESP was similar to the control. In the second trial, lumbar ESP block was compared with infrainguinal fascia iliaca block for pain management after total hip replacements. Lumbar ESP block and fascia iliaca block both provided similar postoperative analgesia. In the early postoperative period, erector spinae block provided favorable pain scores. In the third trial by Divan et al., where lumbar plexus block and lumbar erector spinae block were compared for postoperative pain relief after proximal hip fractures and femoral nailing, this study showed that lumbar ESP block was superior to analgesic outcomes with a low incidence of adverse events compared to a lumbar plexus block. In the last trial of pediatric hip surgeries, where ultrasound guided lumbar ESP block was compared with a caudal block for postoperative analgesia, caudal block provided superior analgesia compared with lumbar ESP block. This is a further summary of all the randomized controlled trials of lumbar ESP in hip surgeries. In the first trial, comparing lumbar ESP block versus PENG block versus control in hip arthroplasty showed that both lumbar ESP and PENG blocks were similar and they provided better analgesia than control group. In another study by Chen et al., continuous lumbar ESP was compared with continuous lumbar plexus block. There was no differences in analgesia. Lumbar ESP had a lower risk compared to lumbar plexus block. In a study of proximal hip and femur surgery when lumbar ESP was compared with quadratus lumborum block versus control. Both lumbar ESP and quadratus lumborum block provided similar analgesic outcomes and both were better than control. In the pediatric group, when PENG block was compared with lumbar ESP block in pediatric hip surgery, lumbar ESP and PENG both provided effective analgesia and reduced the stress response. In another similar trial, lumbar ESP and PENG both provided effective analgesia, but lumbar ESP prolongs the time to first analgesic request in the study by Mostafa et al. Finally, we will discuss about the sacral ESP block, also known as the sacral multifidus block. The original description of the sacral ESP block was done by Tulgar et al., who performed the first sacral ESP block on a patient undergoing pilonidal sinus surgery. So they described this as a technique to block the posterior branches of the sacral nerves. As you know, the sacrum contains the median crest, the intermediate crest, and the lateral crest. The block was performed at the level of the S2 intermediate sacral crest, where an in-plane injection was performed under the erector spinae muscle. A volume of 15 to 20 ml of local anesthetic injected bilaterally provided effective analgesia for pilonidal sinus surgery. Subsequent to the original description of the sacral ESP block, multiple modifications were described. In this modification, in pediatric patients, a single midline injection at the level of S4 was used for pediatric hypospadias surgery. It was performed at the S4 level. The injection was between the erector spinae muscle and the median sacral crest, and a single injection was sufficient for bilateral spread. A further modification of the sacral ESP block is called the sacral foramen block. The modification here is the needle end point was placed under the sacral multifidus muscle at the dorsal entrance of the S2 sacral foramen. Here, an injection of contrast was placed and a subsequent CT scan performed, which showed radiological evidence of contrast spread ventrally to the sacral vertebrae in all patients. There was no dorsal spread, there was no caudal epidural spread. The ventral spread involved the sacral plexus in 100% of the patients, causing a dermatomal loss of sensation between L5 to S5 bilaterally from a single injection. This was used in patients who had cervical cancer and were undergoing brachytherapy. Since the initial description of the sacral ESP block, multiple case reports were then published of expanding clinical indications. The sacral ESP block has been used in pilonidal sinus surgery, anoplasty, hemorrhoidectomy, hypospadias repair, gender reassignment surgery, hip fracture surgery, thigh amputations. They have also been used in labor analgesia during the second stage of labor, for chronic pain, especially lumbar radiculopathy, coccydynia, and vaginismus. They have also been used in total knee arthroplasty, for spine surgery such as lumbar discectomy, interbody fusion, and sacral spine surgery. They have also been used for cervical brachytherapy and also to reduce the catheter-related bladder discomfort after transurethral prostate resection. Cadaveric studies involving dye injection in the sacral ESP block to assess spread patterns show extensive involvement of the sacral multifidus muscle and dye staining the dorsal sacral foramina and entering the sacral canal and the epidural space to stain the sacral nerve roots. Another cadaveric study of the sacral ESP block similarly showed dye staining of the posterior sacral foramina at S2, S3 and S4 levels, also involvement of the sacral plexus and extensive staining of the erector spinae and multifidus muscles. This is a summary slide of all the randomized controlled trials of sacral erector spinae plain block. In the first trial, sacral ESP block was compared with control for post-hemorrhoidectomy pain. Sacral ESP provided effective analgesia and better quality of recovery. In another trial where sacral ESP was compared with a control group for pilonidal sinus surgery, sacral ESP provided effective analgesia up to 24 hours with no complications. In another trial where sacral ESP block was compared with control for the quality of recovery after total hip arthroplasty, sacral ESP was a promising analgesic technique which provided a significantly improved quality of recovery. In the final RCT, where sacral ESP was compared with control for patients undergoing lumbar discectomy, sacral ESP provided better analgesic outcomes with no complications. This is a summary of all the randomized controlled trials where sacral ESP block was compared with an active control. In pediatric patients, when sacral ESP block was compared with a ring block for circumcision surgery, sacral ESP block provided better and effective analgesia than ring block. In patients who underwent hypospadias surgery, when sacral ESP was compared with a caudal block, sacral ESP provided better analgesic outcomes than caudal block. The time to first rescue analgesia was longer. The patients experienced lower pain scores and used lesser amount of opiates. These results were subsequently conflicting in another trial where sacral ESP was compared with caudal block in hypospadias surgery again. Here, the caudal block patients had a longer duration of analgesia and lower pain scores compared with the sacral ESP block. In patients who had catheter-related bladder discomfort, sacral ESP and pudendal block performed similar in reducing catheter-related bladder discomfort after TURP surgery. Sacral ESP was quicker to perform compared to pudendal blocks. Sacral ESP, when performed at the S2 level, at the level of the intermediate crest, should be performed bilaterally. At the level of S4 median crest, a single injection of a large volume is sufficient for bilateral effect. A sacral foramen block is a single injection at the S2 sacral foramina dorsally where a bilateral effect of the ventral sacral plexus is obtained. In summary, the erector spinae plain block is a very versatile block with multiple extrathoracic uses. The cervical ESP block or high thoracic ESP block may be another diaphragm sparing alternative for shoulder surgery. The lumbar ESP block is an effective analgesic option in lumbar spine surgery. Multiple RCTs show similar efficacy of lumbar erector spinae block to infrainguinal block, PENG block, lumbar plexus block, or quadratus lumborum block in hip surgeries. The sacral ESP block is a promising technique for sacral and perineal analgesia. I thank you very much for your attention.